All right, thank you, everyone. So today we'll be talking about hypertrophic obstructive cardiomyopathy, choosing the best therapy in the era of cardiac myosin inhibitors. Disclosures at the bottom. So we'll start with the case. This is a 46-year-old female who was referred to us, and she has obstructive hypertrophic cardiomyopathy, and she was treated with metoprolol and disopyramide at maximum tolerated doses. Despite this, she was symptomatic, New York Heart Association Class 3 symptoms, unable to walk from her front door to her mailbox. Her echocardiogram in our office showed an LV outflow tract obstruction of 135 millimeters of mercury, LVEF greater than 60%, severe septal hypertrophy, and systolic anterior motion of the mitral valve, or SAM, with mild mitral regurgitation. So the question is, does this patient need surgical evaluation for septal reduction therapy? So let's keep this case in mind. So as an overview, hypertrophic cardiomyopathy is a genetic cardiomyopathy caused by mutations in the cardiac sarcomere. It's a heterogeneous phenotype with a spectrum of LV thickening with associated sudden cardiac death, heart failure, and stroke. Its prevalence is 1 in 200 adults, and therapies include treating obstructive symptoms with medications, which we'll talk about, atrial fibrillation with anticoagulation, including warfarin, and then the prevention of sudden cardiac death with implantable cardiac cardioverter defibrillators. It's a genetic mutation of the sarcomere proteins, and it's the most common monogenetic cardiovascular disorder in an autosomal dominant pattern. There are multiple genes that encode thick and thin filaments of the cardiac sarcomere that may be involved, including beta-myosin heavy chain as well as myosin-binding protein C. So the pattern of hypertrophy can be varied. You can have basal septal hypertrophy, lateral concentric, and apical hypertrophy. Typically LV wall thickness greater than 15 millimeters of mercury, making that diagnosis. So at its root, obstructive symptoms have septal hypertrophy causing an outflow obstruction. In addition to that, you can have systolic anterior motion of the mitral valve causing mitral regurgitation. So of those patients who present with hypertrophic cardiomyopathy, about a third of patients can have obstruction at rest, 1/3 with exercise, 1/3 without obstruction. And those patients who have rest gradients, these patients have obstructive symptoms. And there are a number of different maneuvers that we can do, with, which include Valsalva, amyl nitrate, stress gradients, and cath gradients to diagnose obstructive disease. So right now, the algorithm, as outlined in the 2020 guidelines for the treatment and management of hypertrophic cardiomyopathy, include the following when patients present with obstructive symptoms. You consider beta blocker therapies followed by calcium channel blockers, including verapamil and diltiazem. You avoid high-dose diuretics as well as vasodilators. And if the symptoms persist, you can consider disopyramide. And then if they are persistent thereafter, then you may consider septal reduction therapy. And this can be done with either an invasive approach using alcohol septal ablation, or you can consider surgery in those patients who are eligible for surgical myectomy. Here you can see the two forms of septal reduction therapy. These include surgical myectomy as well as alcohol septal ablation. So cardiac myosin inhibitors are fairly new to the field, an innovative new sort of therapeutic approach to the treatment of obstructive hypertrophic cardiomyopathy. Myosin inhibitors bind reversibly to cardiac myosin. So at its root, hypertrophic cardiomyopathy has increased number of actin-myosin cross bridges, and therapy with cardiac myosin inhibitors decreases the number of actin-myosin cross bridges and decreases the amount of hypercontractility that lead to the pathogenesis of obstructive hypertrophic cardiomyopathy. Mavacamten is first-in-class medication. It's a selective allosteric inhibitor of myosin, cardiac myosin, ATPase, which reduces actin-myosin cross-bridge formation. And it was vetted in a phase 2 study called Pioneer that demonstrated improvements in exercise capacity. Its phase 3 trial was pivotal, and this was the Explorer HCM phase 3 trial published in 2020. This included 429 patients who were randomized to mavacamten or placebo. They had obstructive symptoms with LVOT gradients greater than 50 at rest, Valsalva, or exercise, EFs greater than 55%, New York Heart Association class 2 and 3. Its primary endpoint was improvement in peak VO2, or oxygen consumption, of 1.5 with improvements in New York Heart Association class, or 3 with or without an improvement in New York Heart Association class. It included secondary endpoints including a post-exercise LVOT gradients, peak VO2, New York Heart Association class, and patient-reported outcome measurements as well. These are the baseline characteristics of this trial. You had a significant number of patients who had LVOT gradients of greater than 50 millimeters of mercury. About 30% of these patients had genetic roots to their hypertrophic cardiomyopathy, and all patients were on background therapy with either beta blockers or calcium channel blockers. Key study results are as follows. There was a significant reduction in resting LVOT gradients, reduction in Valsalva LVOT gradients, as well as a reduction in post-exercise LVOT gradients from 86 to 38 millimeters of mercury. In addition to that, one of the fears of cardiac myosin inhibitors is that if you're decreasing actin-myosin cross-bridging, you can decrease ejection fraction. Well, seen here, you had a non-significant reduction in EFs with the use of mavacamten seen on the left. In addition to that, you had an indication that wall stress was significantly reduced as NT-proBNP changes were significant with the use of mavacamten. So the next question is, will myosin inhibitors delay septal reduction therapy, such as in the case we presented initially? Septal reduction therapy is recommended for patients who have persistent symptoms with LVOT gradients greater than 50. So this was looked at in the VALOR HCM trial, which took 112 patients and randomized them to mavacamten or placebo. These patients had obstructive symptoms, and in this trial they found that those patients who were randomized to mavacamten at the end of 16 weeks, about 18% still met criteria for septal reduction therapy or underwent such therapy, versus 77% in the placebo arm who still met criteria or who underwent septal reduction therapy. In addition to that, the other question now is, are there structural changes or improvements with cardiac myosin inhibitors? This was demonstrated in 2 studies. At the top there, you can see echocardiographic findings demonstrate a reduction not only in LVOT gradients, but improvements in diastolic dysfunction, as well as left atrial volume indices. This was also shown in an MRI sub-study that showed reductions in LV mass index, wall thickness, EFs, and improvements in left atrial volume index with mavacamten. Now, the drug does take echocardiographic-based medication titration, so you have to have regular echo assessment required for therapeutic effectiveness and to monitor complications. In addition to that, there are a number of drug-drug interactions, especially with CYP A3, A4 inducers and inhibitors, so you have to have special attention to the medications that are contraindicated with mavacamten. Aficamten is a next-in-class selective myosin inhibitor, and it's unique in that it does not have those same med-med interactions. Also, it's a quicker on and off, so if you have an adverse reduction in your EF, you can quickly stop it and have a restoration in your EF. It was vetted in the phase 2 trial called Redwood HCM, and this determined the safety and efficacy of aficamten. And seen here, you can see a reduction in LVOT gradients, both at rest and with Valsalva, and a insignificant reduction in EFs, and in the 2-week washout, immediately these patients returned to baseline, so quick off there. So just hot off the press is this, Sequoia HCM. This is a pivotal trial using aficamten for obstructive hypertrophic cardiomyopathy. And this was just a press release. And aficamten significantly improved exercise capacity compared to placebo, increasing peak VO2. And this was in all subgroups, including those on background beta blocker therapy. So, coming to our conclusion, so the treatment algorithm for symptomatic obstructive hypertrophic cardiomyopathy, so once you go through beta blockers and calcium channel blockers, you want to consider mavacamten in these patients. However, we're now looking at a potential paradigm shift, and an ongoing study that we have here at Texas Heart Institute is the MAPLE HCM, aficamten versus metoprolol upfront for obstructive HCM. So we'll see if there's a role for these drugs initially. There may also be a role in non-obstructive disease, and this has been vetted in a phase 2 trial called Maverick, and now there are phase 3 trials, both with mavacamten and aficamten, the aficamten arm, which we are participating in here as well, looking at these drugs in non-obstructive disease. So let's get back to our case in conclusion. This is our 46-year-old female, significant gradient with 5 milligrams of mavacamten. The reduction in the gradients is pretty significant. But now at 10 milligrams, she has reduced her gradient to less than 25 millimeters with Valsalva, and now she's walking 2 miles. So in summary, these myosin inhibitors are a novel therapy for obstructive HCM. Mavacamten is the FDA-approved drug right now. Aficamten is being studied. Look out for its phase 3 publications. These may become first-in-line therapy for obstructive HCM, and it may delay the need for septal reduction therapy. And finally, they may have a role in obstructive disease, and non-obstructive disease as well. I want to thank you for your time and the invitation.